Hello and welcome to the website of the Queen's Healthcare Leadership Forum. I'm Adam Dolby, Chair of the Queen's Healthcare Leadership Forum, and welcome to the second part of our Aspiring to Excellence series, which covers the Francis Report. This part of the presentation is based on the Francis Report event that was held in Riddle Hall on the 8th of May 2013, so I would like to thank the speakers who were present at that event. Oriel Brown of the Public Health Agency, Tony Stevens of the Belfast Trust, Hugh McCaughey of the South Eastern Trust, and Glenn Houston of the RQIA. So in part 1, we covered systems and system failures. In this part, we're covering the Francis Report. And in part 3 of the Excellence series, we're going to look at some aspects of quality in healthcare. So, part 2. So, an overview of part 2. We're going to start off by looking at what the Francis Report actually is. Then we're going to look at what happened in Stafford, what the warning signs were, what issues were raised by the inquiry, what recommendations were found, and then we're going to summarise by having a look and seeing why this is relevant to students of healthcare. So, Mid Staffordshire and the Francis Report. So, Mid Staffordshire is of course in England, and when it hit the news, it was all over the headlines, it was on the front pages for weeks and weeks. But this is an interesting tweet from somebody who was at a conference of medical students in May 2013, just as it was hitting the news. And at a conference of over 200 medical students, 3 had heard of the Francis Report, in a room full of medical students in England, which suggests there's quite a few medical students not reading newspapers, and probably should really be reading newspapers and following the news, because patients talk about these things and patients are aware of what is happening in the health service in the news, and are likely to ask clinicians such as yourselves in the future of what their opinion is on certain things happening in the news. So the first point to make is read a newspaper. I of course hope that more than 1% of you listening to this have heard of the Francis Report in Mid Staffordshire, and it will be interesting to see in a room full of students how many people have actually heard of the Francis Report in Mid Staffordshire in a year's time, in 5 years' time, in 10 years' time, and see how that changes over time. So the public inquiry into the Mid Staffordshire NHS Foundation Trust scandal was conducted by Robert Francis QC, and he described quite nicely what the overriding story of Mid Staffordshire is. He said, "This is a story of appalling and unnecessary suffering of hundreds of people. They were failed by a system which ignored the warning signs and put corporate self-interest and cost control ahead of patients and their safety." And that's quite a damning summary of what happened in Mid Staffordshire. And we're just going to have a look now into what actually the report revealed. So the Francis Report, its official title being the Mid Staffordshire NHS Foundation Trust Public Inquiry, was launched by the new coalition government in 2010 once they took office. It was an inquiry into multiple failings in patient dignity, care and safety between 2005 and 2009, and was the result of extensive public campaigning by the families of those who felt that their relatives had received poor treatment at Stafford Hospital. There was also extensive coverage in the media, and so the politicians had to give in to the huge public pressure to add to the other inquiry that had been done, but not as a public inquiry, in order to uncover satisfactorily the truth behind what had happened at Mid Staffordshire NHS Trust. So after 2.5 years, the report was finally published on the 6th of February 2013. Remember, the medical students at the previous event had had 3 months to absorb the coverage in the media, and only 2 out of 200 had actually heard of the Francis Report. So over 1 million pages of material was disclosed to the inquiry, 164 witnesses came and gave evidence in person, 87 witness statements and 39 provisional statements were read into the inquiry's report at an overall cost of £13.5 million. At the end of that report, 290 individual recommendations were provided by the team in order to ensure that a scandal such as Mid Staffordshire could never happen again. So I think to summarise best what happened at Mid Staffordshire is best done with a quote from a relative of a patient. This is a quote from a daughter-in-law of a 96-year-old lady who was being treated at Stafford Hospital. She was completely naked, covered in feces. It was everywhere. It was in her hair, her eyes, her nails, her hands, and all on the cot side. So she had obviously been trying to lift herself up or move about because the bed was covered, and it was literally everywhere, and it was dried. It would have been there a long time. It wasn't new. I think this quote summarises fairly harrowingly the kind of treatment that was received by patients at Mid Staffordshire. And it's unacceptable. Of course it's unacceptable for a lady to be left covered in her own feces. Imagine if it was your mother, your grandmother, your aunt, your sister. How would you feel? What would you do? Would you tell anyone? Would you complain? Imagine that you were on placement and you saw this kind of thing. What would you do? Would you say something to the members of staff? So if you're a medical student, would you say something to the consultant or the junior doctor or the registrar? Which one of those three would you pick? If you were a nursing student, would you tell another member of the nursing team or would you tell sister? Just think about if you were in that position for a couple of minutes and think about what you would do and what kind of things would stop you from doing what you see as the right thing and what things would persuade you to do something about it. So at Mid Staffordshire, basic care needs were neglected. Calls to use the bathroom were left ignored by nursing staff. Patients were left lying in the soiled bed sheets. Patients were left sitting on commodes for long periods of time. Patients went unwashed for months. Meals and drinks were left out of reach. There were appalling hygiene standards. Families had to provide care because the care was so bad, and they had to clean the toilets, remove soiled bandages and dressings from public areas. Up to 1,200 patients died unnecessarily over the period. Now remember, that is an above average figure based on standardised hospital mortality ratios. So there's not necessarily a causal link between the quality of care provided at that hospital and the mortality rates. So for example, you can't say that 1,200 deaths were caused by X, Y, and Z. You can just say that according to the trend that's expected, 1,200 patients died above the expected trend. But you cannot necessarily say why. There may be a variety of reasons that are not linked to the poor quality of care that I've just listed. There was a lack of patient dignity and a focus on financial targets by the board and not on patient care. I would take this opportunity to emphasise that there is not a single group of people to blame for what happened at Mid Staffordshire. It goes all the way from the board downwards. It is everybody's responsibility to ensure that patients receive dignified care. It's the doctor's responsibility, the nurse's responsibility, the porter's responsibility, social services responsibility. Anyone who is a professional who visits that hospital has a responsibility to ensure that high quality patient care is received. And if high quality patient care is not being given in that hospital, and if a professional visiting or working in that hospital thinks that there is a poor quality of care being given, it is their job to tell somebody to do something about it in order to stop it happening. There is a professional responsibility of healthcare professionals to ensure that poor quality care is not given in any circumstance, and that where it is seen, action is taken and an attempt made to improve the quality of service being delivered. This is all about whistleblowing. The importance of whistleblowing. You only need to look at the news in recent years to see how many people have been silenced from speaking out about poor quality care. There is now a cultural shift in the National Health Service where these so-called gagging clauses that are in contracts when people leave and prevent them from speaking out about poor quality care they may have witnessed in that institution are becoming unacceptable. So as a result of that cultural shift, the notion that healthcare professionals have a duty as part of their professional responsibility towards patients to speak out against poor quality care and to act where it is seen. An interesting side note being that the gagging clauses that have previously been agreed are no longer being enforced. It would probably be the most unpopular thing any healthcare trust did if they tried to enforce these gagging clauses after somebody had spoken out who was under one. You also need to look back into the culture of the National Health Service, into how whistleblowers have previously been treated. Robert Francis spoke of people who were afraid to speak out at Mid Staffordshire because they were afraid of what might happen to them. And interestingly, a previous scandal that we'll come to later on in this talk, there was a gentleman who spoke out against poor quality care in a children's hospital. He can no longer get a job in the National Health Service because he's been given the label of a troublemaker. So this cultural shift is vital in ensuring that whistleblowers are protected, because whistleblowing is the first step in ensuring that patients do receive good quality care and that dangerous practice is quashed. So what else happened at Mid Staffordshire? Well, there was a focus on financial targets. There was a status in England called Foundation Trust, which basically gave them a little bit more independence from government on what they spent their money on. And so they had to reach certain financial targets in order to be considered for Foundation Trust status. Now, all trusts in England are going to be Foundation Trusts by 2015. So it's a bit of an archaic thing that they have to be awarded Foundation Trust status. But in the past, they had to prove that they were worthy of Foundation Trust status. So there was a mismatch of resources allocated to the needs of the service in order to achieve these financial targets to be able to achieve Foundation Trust status. There were a fear of repercussions for reporting lapses in care, and clinicians were keeping their heads down in order just to keep quiet in the hope that they would not be noticed and not be punished for whistleblowing. And here's an example of a quote from a clinician, a senior consultant who gave evidence to Francis. "Perhaps if my conscience may have made me raise concerns if I had been in a management role, but I took the path of least resistance." Now, I think this quote is important, mainly because it's a consultant, a senior consultant, saying that if he'd been in a management role, he would have brought up these issues. But why should somebody in a management role only bring up these issues? This is about healthcare leadership, which is what the QHLF is all about. It's about an individual who is not necessarily in a leadership or a management position, but is a clinician with a professional responsibility to ensure that patients receive dignified and high quality care. So regardless of whether the senior consultant was in a management role or not, he was likely a respected member of the organisation who could have led everybody into trying to fix the problems that were happening in Mid Staffordshire to prevent the poor quality treatment that was being received by individuals on those wards in that hospital. So as well as what you could see on the wards, and clearly there were obvious issues on the wards with families having to take over the care of their relatives who were staying in the hospital, there were some warning signs otherwise, as well as the things that you could obviously see affecting patient dignity. There was a disengagement of senior clinical leadership at boardroom level. There was no boardroom to bedside ethos, a kind of them and us culture. And Robert Francis at some of his talks has stated that there was a distance, a physical distance between the clinicians and the board. And he shows a photograph of the premises at Stafford Hospital, which show, indeed, there was a distance between the board and the clinicians. There was low staff morale. So they were kind of created a culture where they just accepted what was going on and weren't motivated to implement any change because they thought it was fruitless, or they thought that if they spoke out, they would be punished in some way. There were reports from staff of staff shortages on wards and in A&E, and these were ignored by the trust, who may have been focused more on financial targets in order to achieve Foundation Trust status. There was a review that recommended an increase in staffing in 2007, and this was not addressed. And there were 64 complaints to the Department of Health between 2005 and 2009, and all were ignored. Again, this demonstrates that it was at all level were the problems at Stafford. So not only was it the clinicians on the ward, the nursing staff, the doctors, the porters, the social service workers, the board, it was also at the level of the Department of Health. So the Department of Health were receiving complaints from patients about this hospital, and they were not acting upon it. So the civil service are also to blame as well. So this isn't about a blame game of different people or individual professions. It's about noticing the fact that there was a cultural acceptance of this, and that nothing was acted upon in order to improve the quality of service delivered at this hospital. It's about learning the lessons from this in order to prevent it happening again. So as well as the warning signs discussed on the previous slide, there were also some warning signs from patient surveys. So in 2005, Mid Staffordshire was in the bottom 20% of hospitals, Stafford Hospital specifically. In 2006, a survey said 47% of patients did not want to be treated in their own hospital. Again, in 2006, they were in the bottom 20% of nursing numbers and hand washing, which suggests that they had a shortage of staff, as well as a cultural problem with hand washing. In 2007, they were in the bottom 20% for hand washing, response to call buttons, dignity, and overall quality. And by 2009, they were in the bottom 20% of nearly half of all the categories. Nurse staffing, confidence in doctors' pain control being two examples as well, as the others discussed previously. So again, you were asking these patients what they thought of the hospital, and they were telling you what they thought, but nothing was being done about it. And in fact, between 2005 and 2009, the performance got worse, not better, based on patient feedback. There is no point in asking people what they think of a service unless you're actually willing to do something about it once you've received the data back. So here is a graph just demonstrating what I mentioned earlier about the standardised mortality ratios, and shows that Mid Staffordshire's death rate was higher than the average. But Dr. Foster has said that using hospital standardised mortality ratios and standardised mortality ratios as evidence of deaths attributable to unsafe care is misleading and is a potential misuse of the figures. So again, it's not showing causation, it's showing one of many warning signs, and it may be nothing, but it is something that requires further investigation. So Bruce Keogh, in his Keogh report of summer of 2013, also had something to say on the use of statistics. I quote, "However tempting it may be, it is clinically meaningless and academically reckless to use such statistical measures to quantify actual numbers of avoidable deaths. Robert Francis himself even said, 'It is in my view misleading and a potential misuse of the figures to extrapolate from them a conclusion that any particular number or range of numbers of deaths were caused or contributed to by inadequate care.' So just bear in mind that the statistics that are thrown out by politicians of avoidable deaths cannot be attributed to poor quality care, and that you must be very careful in interpreting such figures." And this is a quote from Hugh McCockey's lecture. "It could not happen here. The 5 most dangerous words in the NHS." So have people looked at previous inquiries in Mid Staffordshire and gone, well, that kind of thing could never happen here? And then it has. So never be complacent about your organisation. Always think, could this be better? Could we be doing something better? Or is something amiss here? So we've covered the warning signs and what actually went wrong according to patients and professionals at Mid Staffordshire. So what issues were raised after all this had been sifted through? Well, Francis identified huge failures of the system, the organisation and the individuals, again emphasising that it's about all professionals at all levels, up to and including the Department of Health. That a fundamental change in culture is required, particularly at Mid Stafford, but maybe throughout the National Health Service. That every single person involved in serving patients needs to be engaged in change. Again, emphasising that it's everybody who should be involved, and that it's not just somebody else's job. Professionals need to be advocates for patients. Again, whistleblowing by professionals is a professional responsibility and is part of their job in providing quality patient care. Remember that patients may not be in a position themselves to complain, or they may feel frightened to complain and that it may affect their care in some way. The job of professionals is to be advocates for their patients. Ward managers need to be visible and accessible to patients and staff so that there's a point of contact for all should poor quality care be occurring. Whistleblowers need to be protected and taken seriously. Again, anyone who speaks out about poor quality care, it takes guts to do something like that, which it shouldn't do. So we need a change in culture that stops it taking guts. But once people have done it, it needs to be acted upon and taken seriously and not just ignored. And core values and standards need to be reinforced. Now, what I've taken on this slide is just something about core values. This is from the Hull and East Yorkshire NHS Trust. And this is on a poster throughout all hospitals within that trust. There's a poster that talks about the values, but then underneath there are these behaviours which allow them to demonstrate their values. So the values are all about ensuring a culture of quality improvement, dignity and respect. And the behaviours that try and achieve that are I will values, so things that members of staff commit to doing whilst they're working for that trust. So, I will look to continually improve the way that my service is delivered. I will look for ways we can rather than reasons we can't. I will look to you and value the opinions of others and treat everyone as I wish to be treated myself. I will always look for things to inspire me and to remember to say well done and thank you. I will remember to make a difference to patient care, quality and safety every day. I thought that this was quite a nice demonstration of the values that Francis was talking about, and the way that you can have a set of values, but you need behaviours that show how you're willing to achieve those values and demonstrate them to patients who you're treating. So what were the key themes of the recommendations? A structure of clearly understood fundamental standards and measures of compliance, accepted and embraced by the public and healthcare professionals, with a rigorous and clear means of enforcement. Openness, transparency and candour throughout the system. Improved support for compassionate caring and committed nursing. Strong patient-centred healthcare leadership. Accurate, useful and relevant information. And I'm going on to now just to discuss the ones that are highlighted in purple. The support for compassionate caring and committed nursing has been in the news recently about making sure that nurses receive a year as a healthcare assistant before going on to further training. And that's just one example of ensuring that nurses are committed and compassionate. Whether it will be effective or not, or whether it's an appropriate thing to do, is up for you to decide, and the politicians and the public at large to decide, and even the nursing students and the nursing profession as a whole to decide whether that's an appropriate way of ensuring compassionate and committed nursing. And also the last point that I'm not going to discuss in further detail, accurate, useful and relevant information, is just providing members of the public with information about their healthcare system, regardless of whether it's bad. We need to ensure that bad news is released to the public, as it puts pressure on the system to ensure that those figures are improved and the quality of care is improved. So Francis talks of fundamental standards. Now, there have been fundamental standards before in the form of the NHS Constitution, so patients come first in everything we do. We value every person as an individual, respect their aspirations and commitments in life. We insist on quality and striving to get the basics of quality care right every time. We ensure that compassion is central to the care we provide. We strive to improve health and well-being and people's experiences of the NHS. Everyone counts. We maximise our resources for the benefit of the whole community and make sure nobody is excluded. These are more values than fundamental standards that Francis talks about, but I'm just using these to demonstrate that this has happened before. We've had the NHS Constitution as a way of communicating the values of the health service with members of the public and with the professionals involved in delivering that healthcare in order to improve its quality. So the fundamental standards have been in the media recently. Things like ensuring that every patient has a drink of water within reach, or that a call bell is answered within a certain period of time, 2 minutes, 3 minutes. these are just basic fundamentals of care, which can be measured by patients. So they appreciate that somebody comes and answers their bell in time, or they appreciate that they have access to water within reach, provided they're not nil by mouth, of course. So the reason I've put these fundamental standards in from the NHS Constitution, which are more fundamental values, is that it's been attempted before as a centralised communication to the profession and to the public at large. And the question for you is, will the fundamental standards go the same way? Will they just be kind of fluffy language that's released by politicians and makes politicians feel good about themselves, but doesn't actually make any difference to patient care? I personally hope not, and I think if something's more specific than these values from the NHS Constitution are, I think it could work. But just have a think about that. Are these just words from politicians rather than things that can actually make a difference to everyday patient care? And I'll introduce Francis's next key theme from his recommendations with a quote, probably one of the most brilliant quotes in healthcare in my opinion, from Sir Liam Donaldson from the World Health Organization. To err is human, to cover up is unforgivable, but to fail to learn is inexcusable. And I think this is what patients expect. They expect that where a mistake is made, we do actually learn from it, and we don't cover it up, and we are completely open about what has happened. So, follow on from that quote, the key theme is openness, transparency, and candour throughout the system. I've defined these because they can become a little bit messed up with each other. Just a note here that Sir Robert Francis had said that students are the underutilised resource in the healthcare service. So think when you're on placement what you can do to help improve patient safety, patient care, quality, dignity, and what position a whistleblowing student might find themselves in. So, on to Francis's themes on that note. Just leave you with that little bit of thought there. Openness is the proactive provision of information about performance, including the negative performance. So you release all data about the service into the public domain to allow people to actually have access to that data and make decisions, informed decisions, about the healthcare that is on offer at your institution. Transparency is the provision of facilities for all interested persons and organisations to see the information they need properly to meet their own legitimate needs in assessing the performance of a provider in the provision of services, i.e. not hiding poor performance behind a wall of indecipherable data. This is slightly different from openness. Openness is about providing the information. Transparency is about not hiding that information by just releasing a wall of indecipherable data to the members of the public. So it's about giving the media the data that they require to make a decision about the health service as a whole, and giving patients information about the health service or the hospital or the institution to make an informed decision about the care they wish to receive and where they wish to receive it. And finally, candour is the other phrase that's used in this key theme of recommendation. And candour is the volunteering of all relevant information to persons who have or may have been harmed by the provision of services, whether or not the information has been requested and whether or not a complaint or report has been made about that provision. So in other words, if you make a mistake, you tell the patient regardless of whether they ask. So you have a heart-to-heart with them, tell them what's gone wrong, why it's gone wrong, and importantly, as per the previous quote, tell them how you're going to learn from it and what you're going to do to prevent that mistake happening again. Of course, with some things, it may not actually be something that you can particularly learn from. So for example, if you're implanting a pacemaker and somebody gets a pneumothorax, that is a known complication with a known rate. So it's not necessarily a medical mistake, it's a known complication of a procedure. But you still need to be open about the fact that that has occurred, that known complication has occurred, and tell them what you're going to do and what the treatment is and what the next stages are. Also remember that from a medical legal perspective, an apology is not an admission of liability. So the next theme is strong, patient-centered healthcare leadership. So again, I need to define leadership. There is, of course, the entire presentation on defining leadership on the QHLF website. It's www.qhlf.co.uk. And if you navigate to the QHLF resources page, there's a vodcast there, but I've just taken a dictionary definition here. So leadership is the activity of leading a group of people or an organization, or the ability to do this. Leadership involves establishing a clear vision, stage 1. Stage 2, sharing that vision with others so that it will follow willingly. 3, providing the information, knowledge, and methods to realize that vision. And 4, coordinating and balancing the conflicting interests of all members and all stakeholders in implementing that change. A leader steps up in times of crisis and is able to think and act creatively in different situations. Unlike management, leadership cannot be taught, although it may be learned and enhanced through coaching or mentoring. So remember, everyone in an organization has a responsibility for taking up the role of leading service change and service improvement. It's all about quality and safety. You do not have to be in a formal leadership position in order to be a leader. You can be a leader by being even the junior doctor on the ward. If you notice something that can be improved, you can have a vision for implementing a change, communicating that vision to others in order to bring everybody with you, to improve service quality, or to improve safety of a service that you're delivering. Remember to put the patients first and foremost in your mind when designing service improvements. It's not a service improvement if it doesn't benefit patients in some way or increase safety. So there's an entire presentation here on Francis. So how is it relevant to healthcare students? So when you're on placement, think, are fundamental standards of care being met on this ward? What do you personally think is a fundamental standard of care? Would you want your family to be treated on this ward? Would you want to be treated here? Report lapses in patient care, poor treatment of patients. Remember that you still, even as a student, have a professional duty to act. Acknowledge the culture. Would you be prepared to speak out as a patient advocate on this ward or in this practice? Is the environment right for encouraging people to give feedback on the service that is being provided, or do people feel as though they will be punished in some way if they speak out against the service? Ask, what performance data is available about this ward, and what does it tell you about the quality of care? Can the data be misinterpreted by patients, professionals, politicians? Or is the data good? Is the data even providing too much complacency on the ward that you're on? Consider, always, how can this service be made better? Patients will trust that you know about mid-staffs so that you prevent it from happening again and do not allow it to happen again. So always remember to consider patient safety, service quality, and the patient experience, on top of the usual realms of quality that scientists consider, such as clinical effectiveness. Coincidentally, for those of you who are interested in patient safety, you can Google a report by Don Berwick of the Institute for Healthcare Improvement, who makes some very interesting recommendations on improving safety in the National Health Service. He in fact poo-poos David Cameron's concept of zero harm, because of course all medical treatments have a potential for harm and a risk of complications. But he says that a strive for improvement in healthcare is never complete, and it's a journey and a continual process of continual improvement in patient safety to reduce the level of harm. Although zero harm is a laudable aim, it may not exactly be possible to achieve such an aim. So if you just Google the Berwick Report 2013, you'll find a very interesting report that I would commend to you. It's a fascinating read, and it's not very many pages, honest. So I've just done a brief slide here on previous NHS scandals, so-called, just to emphasise that these things have happened before. So the Alder Hey organ scandal was the unauthorised removal and retention by teaching hospitals of human tissue that eventually led to the Human Tissue Act of 2004, which is why the dissection suites have such stringent policies on who can go in and what can be taken from them. So what does this tell us about the culture at the time? think about what do you think it tells us about the medical profession, who are just taking organs from people's relatives who've died just for interest's sake, without considering the dignity and the rights of the people that they were taking the organs from. It screams of really an arrogant profession. And the Bristol heart scandal occurred in the 1990s. And this was the gentleman who reported these, who has had to work in Australia due to being given a label as a troublemaker, just for simply whistleblowing about concerns he had. There was a very high mortality rate in infants undergoing cardiac surgery, and he brought it to the attention of the authorities. And the subsequent inquiry found that there was a lack of leadership. The unit was simply not up to the task. There was no boys' culture amongst doctors, a lax approach to safety, secrecy about doctors' performance, and a lack of monitoring the performance by management. So again, this case particularly highlights the importance of culture in not only service quality, but also patient safety and clinical effectiveness. We need to break through these old-fashioned cultures in order to have the open, transparent culture that Francis has talked about. So back to the old gem of a quote, it could not happen here. 5 most dangerous words in the NHS. Think, did people in mid-Staffordshire see the inquiries into Bristol and Alder Hey and think that it couldn't happen at Stafford? And there are repeating themes through inquiries. I mean, look at the Bristol heart scandal, the things that were highlighted on the previous slide. Leadership, culture, secrecy, lack of monitoring. All of these things have been brought up in other inquiries. So why do we keep needing to repeat the past when we've already learnt the lessons? And we go back to Sir Liam Donaldson's quote about the failure to learn is unforgivable. And finally, just to highlight the political difficulty facing any change in the National Health Service, such as that discussed in the patient journey slide previously, in part 1 of this excellent series. This is from the local paper in Stafford, and they've collected 50,000 names to fight the closure of the hospital. Remember, this is after the Francis report. This is dated June of 2013. The Francis report was released in February 2013. So even though there's been national scandal with the hospital in Mid Stafford, people are still petitioning to stop it being closed, despite the appalling lapses in standards of care that were received by patients at that hospital, because people are attached to their local hospital. This highlights just another dimension of how difficult change is in the National Health Service, and how dangerously political it can be, and how difficult it is. And the effects of actually keeping hospitals open can increase mortality, because you end up providing a reduced standard of clinically effective care in a specific local hospital, even though you want to centralize it. An example of this could be that in order to justify keeping a local hospital open, you offer thrombolysis of STEMIs, whereas thrombolysis doesn't have as good an evidence base behind it as primary PCI does. Whereas if that local hospital had closed, everyone would have to go to get primary PCI at the centralized tertiary centre. So people petitioning against closures of hospitals can make change to improve patient care very difficult indeed. And there's a quote from Nigel Lawson, former Chancellor of the Exchequer. The NHS is the closest thing that the English have to a religion, and this makes it particularly difficult to have a rational argument against, and it's why education of the public at large as to why certain changes are important is vital in improving healthcare services in our National Health Service. So is this where the danger lies? And I'll end this talk there with that little food for thought. So thank you for listening to the second part of the Aspiring to Excellence series by the Queen's Healthcare Leadership Forum. You can join the mailing list by emailing healthcareleaders@qub.ac.uk. You can follow us on Twitter at QUB Health Leader. You can find us on Facebook, or you can visit our website at www.qhlf.co.uk. We also host a local experience network, information about which you can find on our website. And you can also offer to join the committee by emailing healthcareleaders@qub.ac.uk, We are a multidisciplinary society at Queen's, and so we ask for representatives from across professions on our committee. We have nursing represented, pharmacy represented, dentistry represented, as well as medicine represented. Thank you for listening, and the third and final part of this talk will follow within the next couple of months. I hope to see you at future QHLF events in the current academic year.